Okay, so get started. Thank you everyone for joining the first journal club, ANZSA Journal Club for the year. So welcome everyone. Before I start, I'd like to acknowledge the traditional custodian of the lands on which we are meeting today. So I'm Sydney, I'm on the Cuyegkeng land, 65,000 years of culture, one of the oldest in the world. I'd like to pay my respect to the elders past, present and emerging and recognize their very deep connections to the land, sea and sky. So thank you for joining. So today we'll have two presentations. So each one will go for about 20 minutes. Then we'll have about 10 minutes discussion at the end of each presentation. Feel free to put in messages in the chat room during the presentation. And you probably saw some of the highlights in the holding slides, some of the upcoming events. So there's the sarcoma research grant that is open at the moment for application. 2 grants, each one is about $50,000. The ASM is on in October in Cairns this year. And of course, we have our Plankathon. It's going to be in June this year. So hope you can all join and sign up and promote the event. So the first presentation is by Valerie. Valerie is a Radiation Oncology Fellow at Bristol Brown Life Health. She's actually come from Philippines and spending a year with us. So thank you, Valerie.
Hi, everyone. I'll share my slides. Okay, does everyone see my slides?
Yep, all good.
So for today's journal club, I'll be sharing a systematic review that's comparing stereotactic body radiotherapy versus surgery or metastectomy for lung metastases in sarcoma patients. So this paper was actually published late last year, and it wanted to analyze the safety and efficacy of using SBRT versus surgery for the treatment of lung metastases in our sarcoma patients. So as a brief background, and as we all know, soft tissue and bone sarcomas are very rare. However, for those that have sarcomas, 30% of them develop pulmonary metastases even after curative intent. Lung metastases are associated with poor prognosis, and the standard local therapy that's done is a surgical metastectomy. However, SBRT is now being increasingly used as a non-invasive alternative for these patients, but a direct comparative evidence remains limited for this. So the objective of this systematic review is just to pull all the studies that they could find that could compare surgery versus SBRT or stereotactic body radiotherapy for the treatment of sarcoma lung metastases. The endpoints that they wanted to show were local control, progression-free survival, disease-free survival, overall survival, as well as treatment-related toxicity. So how they did the review was following PRISMA guidelines. They first did identification using databases such as Medline or a PubMed search, as well as a manual reference search, and they actually got about 319 papers. After which, the only ones that they included reported on sarcoma and pulmonary metastases, and treatment was either surgery and or SBRT. So following that, they screened 101 records. Publications up to May 13, 2025 were included. And after screening, they excluded articles that were not in English, those that were guidelines, those that were letters to the editors, reviews, meta-analyses, or case reports, as well as others. So after screening, they were able to gather 58 studies that totaled a cohort of 4,787 patients. So just the characteristics of the studies that are included in this systematic review. So again, there's 58 studies in total, most of which were published from 2005 all the way to 2025. Median cohort is about 61 patients per study. However, there were no randomized controlled trials found, and there was only one study that was published in the 90s that was included in the systematic review. So as for treatment focus, 41 of the studies were on surgery, 13 on SBRT, and only 4 actually compared surgery to SBRT. Median patients per study were 61 for surgery and 33 for SBRT. And median pulmonary metastases per patient were about 4 in surgery and 2 for SBRT. Mostly the studies were retrospective in nature, 88% of them. And for treatment distribution, there were 4,145 patients in the surgery arm and 642 patients in the SBRT arm combined. However, when looking at histology, because sarcomas really are rare cancers, 42% of the studies had a mixed histology, so different histologies of soft tissue sarcomas and bone sarcomas were lumped together and were compared for their with either a metastectomy or SBRT. Median follow-up was about the same at 33 or 34 months. So for treatment characteristics, the surgeries done for these metastectomies were all varied. Some were through thoracoscopy, some with thoracotomy, sternotomy, and some actually not also confined to just one type. 28 studies that were included in the analysis included R-positive margins. For SBRT, on the other hand, there was also a diverse range of total doses, 20 to 60 gray. Fractionation was also varied from 1 to 12 fractions, and a BED or biologic equivalent dose of 60 to as up to 360 gray. So first they looked into local control, and they saw that there was actually a high local control rate for both modalities. At 3 years, surgery showed 89.6% and SBRT an 87.8%. However, the definitions of local control were more consistent with the SBRT studies. For surgery, because they've already taken out the tumor, local control was kind of made equivalent to regional control or pulmonary failure or recurrence. So this direct comparison is actually limited by this heterogeneous reporting of outcomes. Progression-free and disease-free survival was inconsistently reported. For example, for surgery, progression-free survival was missing in 43 of the 45 studies that were seen. For SBRT, progression-free survival was missing in 15 of the 17 studies, but they do state in the paper that generally they're very low and it reflects the dominant impact of systemic disease progression. However, if we look at it, progression-free survival at 4 years was about 27.5% in surgery for those that reported it, and 21.2% for SBRT, with no clear superiority of surgery or SBRT. The most frequently reported outcome was overall survival. So they did a pooled overall survival analysis, and they found that there was no statistically significant difference between SBRT and surgery. The p-value is at 0.27, and 5-year overall survival for surgery is 37.8% versus 31.6% for SBRT. So on the graph here on the right, they do show that there is an overlap with the confidence interval. So in orange is SBRT and in blue is surgery. And these survival curves largely overlap, and it appears to be driven more by systemic disease biology than actual local treatment. In terms of toxicity, surgery did show higher severe adverse events. Reported complications included pneumonia, prolonged air leak, pneumothorax, and cardiac complications. There were grade 4 to 5 toxicities reported in the papers, and surgery did have a mortality observed. On the other hand, SBRT does have a more favorable toxicity profile. Mostly it reported grade 1 and grade 2 events. There were no grade 4 or grade 5 toxicities and no mortality. And the common effects that they saw was just radiation pneumonitis or chest wall pain. From the 4 studies that directly compared SBRT versus metastectomy, 3 of the studies had comparable outcomes for local control, progression-free survival, and overall survival. There was one study that focused on chondrosarcoma alone that favored surgery. However, when looking at the data and the patients that were included, SBRT was only limited to inoperable patients that had poor KPS or performance status. So the key findings of this systematic review is that surgery and SBRT offer comparable oncologic outcomes. They had similar high local control rates of 90% in 3 years. However, it is always noted that, again, like I said before, like surgical local control versus SBRT local control was not equal or equivalent. When we resect a tumor, there's a different biological endpoint that needs to be observed. SBRT is associated with lower treatment-related toxicity, with no grade 5 or mortality seen. Outcomes are largely driven by systematic disease progression, which is why progression-free survival and disease-free survivals remain low. Overall survival was the only outcome that had a pooled analysis, and although surgery scored a slightly numerical overall survival advantage, it was not statistically significant. So the authors actually state that they think that SBRT should not be viewed as a salvage option. Treatment should be individualized per patient. We have to consider a patient's comorbidities, the number, the size, and location of metastases. There is also no strict definition of what oligometastatic disease is in sarcoma and which patients would actually have the benefit derived by treating all metastatic sites. We should also do a multidisciplinary sarcoma team in order to determine the best treatment given to each patient. And SBRT is a valid alternative to surgery for select patients. It should not be regarded as merely a fallback, and it might be as effective and potentially less toxic than surgery. As well as with newer stereotactic radiation techniques, we do have an option to dose escalate to improve outcomes. So the authors actually also state that instead of always looking at overall survival, we might look into other goals or other endpoints, such as systemic therapy-free survival for oligometastatic patients. Some limitations to the systematic review. It's all predominantly retrospective data at 88%. There's no randomized controlled trial that was found. There was heterogeneous outcome definition, such as that for local control. There's incomplete reporting on progression-free and disease-free survival, and they could not limit all confounding factors due to the retrospective data that was worked with. And in conclusion, they state that SBRT and surgery provide similar survival and local control. SBRT offers a more favorable toxicity profile and should be considered alongside surgery, not after it. Prospective trials are still needed to define the optimal patient selection. And thank you so much.
Thanks, Valerie. I'll open this up for discussions. Anyone have any comments or questions? Okay, maybe.
Sorry, just.
Yep.
Hi. Thanks, Valerie, for that talk. Just a quick question around dose fractionation. Obviously, as you're saying in your talk, there's a wide range, and like the BED range from 60 to 360. Did they quote, so I guess, like a average or mean BED in these studies, or was that not really available?
It was actually not stated in the paper. However, I think they also stated that if you look on the timeline, there was a big shift from older studies using different fractionations, whereas like newer studies had higher BED doses and more standardized fractionations used.
I'm actually interested to hear the practice among different centers in terms of preference for surgery or SBRT for someone with 1 or 2 sarcoma met. Anyone want to jump in and comment, or Gareth, or what do you do at your center? Or?
So I'm based in Auckland, so I guess with the North Island sarcoma service in New Zealand. I think as a general rule, most of the time we would favour surgery if they're well enough, but I guess I'm trying to encourage SBRT as a good alternative. Yeah.
Okay. All right. What about like Peter McLeese, is you online?
I am. Don't mind me in my little blanket.
Oh, where are you?
I'm Peter Mac. I'm just cold. It's cold. Yes. I can't really, I'm trying to think if I've had any case. I don't know that I can speak to it yet. Sorry, my experience here isn't enough to know. Do we use it? Yes, but which cases, I'm not so sure.
Yeah. Okay.
Angela, it's Maddie here.
Yeah.
Can you guys hear me? Sorry, I'm just in the car.
Yeah.
I guess I think this is quite topical because I think it's been on my mind, I think more recently, as to what our approach is for, oligometastatic disease, how we define it, what our kind of optimal approaches should be. And I guess I'm interested to know if other centres have like a dedicated sarcoma thoracic kind of MDT, because I feel like certainly at our centre we have a dedicated thoracic MDT which we can take our sarcoma patients to, but again I tend to personally not go to that particularly regularly and just do things sort of offline. But I know at the Royal Marsden they have like a dedicated thoracic sarcoma MDT which is like between the Marsden and the Brompton, and I do wonder whether we should be thinking more about that approach and whether that's a state-based thing or whether there's, depending on how many cases, whether we should be aligning ourselves. Anyway, interested to know thoughts on that, and if any other centres do have a more dedicated approach to how they're managing the sarcoma lung mets.
Yeah, maybe we don't have a specific thoracic sarcoma in Brisbane. We do have thoracic surgeon who's got a special interest in sarcoma, but they have theatre that actually clashes with the MDT, so sometimes it's actually hard for them to attend.
So what's your approach in Queensland in terms which way?
So usually if we have someone that's for thoracic opinion, we have to give them heads up to make sure that at least either the surgeon can attend or someone from the team, or sometimes we just have to discuss them outside of the meeting.
Yeah. Okay. But are you guys more in favor of surgery or SBRT, or it just depends on the case by case?
Yeah, it depends on the case by case, the number of lesions, whether unilateral, obviously, or whether it's on both sides, and the location. So certainly, we get a cardiothoracic opinion first. We got red-oncs regularly in the meeting, so they're always happy to discuss and make a plan.
Maybe Valerie, you can briefly talk about location and size and limit of what we can do with radiation or area, what we call no-fly zone. Yeah. Or Gareth, if you want to jump in. Or...
Is it me or?
Yeah. Why don't you go first?
Yeah. So for SBRT, I guess we usually limit the size to 5 cm and below for a lesion in order to deliver a high ablative dose. And then I've seen a couple of fractionation schemes, but they could actually do a 60 gray and 8 fractions if it's within what we call a no-fly zone, which is the area that's around organs at risk at the in the mediastinum, like the great vessels and the great vessels and your airway, because there is a high risk of actually causing to puncture that with higher radiation dose. So, but they do often, they have a paper that was published in Canada where they use a 60 gray and 8 fraction regimen for that, and it's still really safe and it's still really effective with high local control, even if they underdose areas in order to actually limit going over dose constraints for those organs at risk. Yeah. but I've seen them like 5 cm, even greater than 5 cm, as long as they're given a good enough dose coverage in most of the volume. Then sometimes they still try to push for SBRT versus surgery, especially for patients that aren't able to go into the theaters and get it resected.
Great.
Valerie, it's Maddie here again. Sorry, just a quick question. In your reading around this sort of topic, did you come across any papers that used a combination of sort of surgical techniques and SBRT? Or is that something anybody else has experiences with, where you could use a combined approach?
In this paper, they actually didn't do a combined approach. I'm not too sure if there is one. If I do a literature search, that would do a combined approach. But basically for this systematic review, they wanted to just compare outcomes for surgery alone versus SBRT alone.
Yeah, because I think I had a patient who was planned for bilateral sequential metastectomies, but then did one side, and then the other side there was concern about not enough lung function, and I guess usually that should be planned from the get-go, but I think the patient got a bit of cold feet and then decided not to proceed, so we're just observing him at the moment. But I had been considering whether then you would consider SBRT to the other side as an alternative, but yeah, it might be something that I don't know whether we could study that prospectively or.
I think that's reasonable too. Yeah, the other side. Yeah.
Can I ask, is anyone using interventional radiology or any ablative procedures for lung mets?
We don't tend to do a lot, cryoablation. No, not really. No. I don't think the data is as strong as surgery or SBRT in terms of the local control. We don't tend to do it.
Yeah, no, we don't use it much either, but we didn't have it available at all. The interventional radiologists only started attending the meeting in the last few months, but still sort of finding their role. There was one patient who sort of progressed in the SBRT field, and that was one indication.
Right. Okay. Any other comments? Otherwise, we'll thank you, Valerie. So I'll get Stephanie to share her screen. So Stephanie is our medical oncology sarcoma fellow. Just started about a month ago at Crystal Brown Lifehouse with Peter, Maddie, and Viv. So I'll get you to share your presentation.
All right. Can everybody see my slides?
Yep, all good.
Good. So as you mentioned, my name's Stephanie. I'm the sarcoma fellow here at Lifehouse, and tonight I'll be primarily discussing the DeFi trial of neurogist. Oh, I tried this so many times at home. Neurogassistat for desmoid tumours, including the updated long-term results that were published last year that looked a little bit more at toxicities and the longer-term outcomes. So I will just very briefly start with a little bit of background. Desmoid tumours are rare, non-metastasizing but locally aggressive myofibroblastic neoplasms. And whilst they're not malignant, they can contribute significantly to morbidity. They're characterised by a high recurrence rate after surgical resection, and they typically arise in young adults with a female predilection. Radiologically, they classically appear as ill-defined and infiltrative masses extending along fascial lines, and they can cross compartments. Just because it's relevant to the way that neurogassistat works, I'm just going to briefly run through the pathobiology. So desmoid tumours are characterised by somatic mutations in CTNNB1 and hereditary mutations in APC. Both of these abnormalities result in abnormal constitutive activity of the Wnt pathway. So these diagrams illustrate the Wnt pathway in A when it is inactive and B where it is active. So in the presence of, A is in the absence of the Wnt ligands, there's an absence of signalling, and therefore the transcription factors are inactive and their gene expression is suppressed. In that situation, the cytosolic beta-catenin is sequentially phosphorylated and targeted for destruction by what is called a destruction complex, and that maintains low levels of the cytosolic beta-catenin. When you have a Wnt ligand present, that causes two cell membrane proteins, frizzled and LRP5/6, to bind and induces phosphorylation of the LRP5/6. And what that does is recruits proteins that are integral to the destruction complex to the membrane and thereby inactivates the destruction complex. As a result, the beta-catenin accumulates in the cytosol because it's not been destroyed, and then translocates to the nucleus where it binds to transcription factors and activates expression of target genes, which include growth factor pathways. Thus, the mutations in APC, which results in decreased destruction complex activity, and in beta-catenin, which results in increased beta-catenin levels, are both pro-oncogenic. The link to this pathway, which is critical for desmoid tumours, occurs through, and the treatment that we're looking at today is through the Notch pathway. Notch also regulates cell proliferation. It's activated by a series of peptidases, so alpha secretase and gamma secretases. And so dysregulation of gamma secretases can result in increase in the Notch activation, which drives proliferation, and conversely, which is what we're doing when you use nirogacestat, which is a selective small molecule inhibitor of the gamma secretase, you reduce the activation of Notch and therefore reduce the growth signal pathways. There is crosstalk between the Wnt and the Notch pathways, so manipulating the Notch pathway also has flow-on effects to the Wnt pathways. So DeFi was a phase 3 double-blinded randomized placebo-controlled trial. It was a two-part trial. The first part was a double-blinded study, and the second part was an open-label extension where patients in the control arm were able to cross over to active drug, and those already on nirogacestat were able to continue the therapy. So at the outset, they were recruited 142 patients who were allocated in a one-to-one allocation to either nirogacestat 150 milligrams twice a day or placebo twice a day. And the primary outcomes were objective response rates, progression-free survival, patient-reported outcomes, and safety. Of the 70 patients that had initially been randomly assigned to nirogacestat in the blinded phase, 39 continued on treatment in the open label expansion, and it was this small group of 39 patients that were included in the updated trial outcomes from the last year's update. So overall, 33 patients received active drug for at least 3 years, and only 15 patients received it for at least 4 years. Looking at baseline demographics, they were well balanced and do reflect the population that we see in clinics reasonably well, with a median age in the early to mid 30s and a female preponderance. The tumours, desmoid tumours, were predominantly extra-abdominal and predominantly CTNNB1 mutations, with a rate of about 60%, which is perhaps a little lower than anticipated. and then the minority of patients with APC mutations in the order of about 15 to 18%. With respect to prior treatments, most of the patients had refractory and recurrent disease with a median number of 2 prior lines of therapy before starting the trial drug. And the prior therapy had included chemotherapy in about a third, other tyrosine kinase inhibitors in about a third, and sorafenib in about a quarter. Around a half of patients had undergone prior surgery and almost a quarter had had prior radiation. The updated response rates were presented that showed a 4-year objective response rate of 45.7% and a clinical control rate of approximately 90%. So there were 24 partial responses, or a third of patients, and 8 complete responses, which equated to about 11.4%. Over the course of time, this so as people were exposed to drug for longer, there was a progressive increase in the number of patients achieving a partial response. So an additional 10% of patients showed response in prolonged treatment with the drug. So there were reductions in the target tumour size that continued throughout longer-term treatment with nirogacestat, including in those with stable disease. So reductions in tumour volume, even if still classified as a stable disease. And the median reduction at 4 years in tumour volume was 75%, compared to 1 year where it was 32.3%. And the spider plot on the right there illustrates the clinical response of lesions over time and reduction in size. Looking at PFS, nirogacestat was superior to placebo. As of the final long-term data cut-off date, the median PFS was not reached. And there were no additional events, progression or death that occurred with additional exposure after 2 years, which is indicated by the plateauing of the curve in that bottom PFS curve. The stable PFS at years 2 to 4 of 78.8%. Given that this is not typically a fatal condition, symptomatic response is one of the more significant outcomes, as it's often the symptoms that have prompted treatment initiation. So there was an early and sustained reduction in both pain and total symptom score within 3 months of starting treatment. There was a reduction by about 1.5 standard deviations in pain and 1 standard deviation in total symptom score in approximately 2/3 of patients. And that was maintained throughout the follow-up period. At 3 years, 47% of patients remained on active treatment compared to only 21% after 4 years. And the most common reasons for discontinuation were toxicity in 26% of patients. 17% of patients discontinued therapy due to progression. 16% discontinued therapy at the end of the open label extension phase, and 14 discontinued by choice. The most common treatment-related adverse events were diarrhea in 81%, nausea in 52%, fatigue in 46%, hyperphosphatemia in 39%, and also rates of ovarian toxicity, rash, stomatitis, and headache. The majority of the toxicity was grade 1 or 2, and dose reduction to 100 milligrams twice a day was mandated to manage grade 3 or higher toxicity, and was optional for the grade 2 ovarian dysfunction. You can see in the graph on the right that the incidence and severity of the treatment-related adverse events did decline with ongoing exposure. That does take into consideration that some patients would have had dose reductions as well in that time to manage it. But by their 4th year of treatment, only about 15% of patients had ongoing grade 2 diarrhea, and only about 10% had hypophosphatemia, and headaches and stomatitis were also relatively uncommon. I quickly wanted to look at ovarian toxicity in a bit more detail, because patients presenting with desmoid tumours are young, and the potential impact of premature ovarian failure or dysfunction has both medical and social implications. So there was a retrospective analysis of the DeFi cohort, and they identified that any grade ovarian toxicity occurred in 75% of females of reproductive potential, so 27 of 36 patients who would otherwise have been undergoing regular menstrual cycles. So of those patients, 11 patients, so not quite half of them, stopped treatment for any reason. And 14 patients continued on treatment and 2 patients were lost to follow-up. In the group, the 40% or 11 patients that stopped the nirogacestat, 4 patients ceased specifically due to toxicity, ovarian toxicity, and the remainder for other reasons. And in that group, ovarian toxicity resolved in all patients, so there was no long-term ovarian toxicity that was identified. In the group of patients that continued on nirogacestat, the ovarian toxicity resolved in 70% of patients, so even with ongoing treatment, it did in fact resolve with time, but did continue in approximately 30% of patients. Just in terms of access, there is no PBS listing. It's not TGA listed, but it is available via an access program. So in summary, nirogacestat was associated with significant benefits with respect to PFS, objective response, pain, and other symptom burden. And although adverse events were frequent, they were mostly low-grade toxicities. In women of childbearing age, though, there is a significant risk of ovarian toxicity, which does largely appear to be reversible on treatment discontinuation. I suppose we're still left with some questions regarding what the optimal sequence of other strategies and perhaps even what the optimal duration of treatment with systemic therapy is for these patients. So to help look at that, I was just going to look at the evidence for some other systemic therapies, particularly sorafenib and some chemotherapy. So this data is a little bit older. It was presented in NEJM in 2018. It was a phase 3 double-blind placebo-controlled trial involving 87 patients who were allocated 1-to-1 to receive either sorafenib 400 milligrams daily, which is a slightly lower dose, to full dose sorafenib, or placebo. Crossover was permitted on progression, and dose reductions to 200 milligrams daily were permitted for toxicity. And the primary endpoints was progression-free survival with secondary endpoints, objective response rates, and adverse events. Looking at the demographics, I think they're relatively comparable to the DeFi study, so similar number had undergone prior surgery. Fewer patients had undergone radiation, 10% compared to 20%, and there were lower rates of prior systemic therapy use, 40% compared to 60%. At a median follow-up of 27.3 months, sorafenib was shown to significantly prolong progression-free survival compared to placebo, with a 2-year PFS of 81%. compared to placebo of 36%. Like what we saw in the DeFi trial, it does look like there is, we're starting to see a plateau emerge towards the end of the follow-up period here. The objective response rates were 33% with what looks like a 100% disease control rate, compared to 20% in the placebo arm. Toxicity was as expected for sorafenib, so rash, palmoplantar erythrodysesthesia, fatigue and hypertension and diarrhea were some of the more common side effects, as well as nausea and mucositis, and 14% of patients stopped treatment due to adverse effects. A further 18% stopped due to progressive disease on therapy. There was an interesting separate study, so looking at a different population of patients. It's a retrospective study that looked at outcomes of discontinuation of sorafenib. So it looked at patients who had discontinued sorafenib for any reason, but who did not have any immediate plans or immediate need for new treatment. So of the patients that they studied, 17 patients stopped therapy due to side effects, and the remaining discontinued for other reasons, including patient preference, provider decision, or payment coverage. What they found is that the risk of progression was low. So during the follow-up period, only 4 patients had progression of disease, so 8%. While the remainder had ongoing stability of their disease. They did find, and I think their analysis is limited by numbers, but they did find that for people receiving treatment for less than 6 months, their treatment-free survival was lower, so it was 10.1 months compared to those who received more than 6 to 12 months, where their median treatment-free survival was 54.5 months. So I think it's limited because there were only 3 patients who did receive less than 6 months of therapy, but nevertheless it does appear that people who received 6 to 12 months of sorafenib therapy might experience prolonged treatment-free intervals with a low rate of progression in early subsequent years. There was another discontinuation trial. This one was Indian-based and a prospective phase 2 trial where patients who had been on sorafenib for at least 12 months were enrolled and underwent planned discontinuation. And their primary endpoint was the 1-year progression-free survival. What this showed is that progression-free survival at 12 months after discontinuation was very high at 90% and was stable between 24 months and 36 months at 74.5%. They comment that the post-discontinuation progression was infrequent and was managed with either retreatment or observation. Again, this is not available on the PBS or TGA listed, but there is a free compassionate access program available. There's been studies of other small molecules inhibitors. They're relatively less impressive, particularly imatinib, which probably had outcomes that were similar to what we see in active surveillance studies in terms of progression-free survival, perhaps marginally better. Briefly looking at chemotherapy, so there's evidence for a large number of different regimens. I was just going to touch on anthracyclines and paclitaxel as they have some of the more recent data. there was a retrospective multi-center cohort study that compared outcomes of sorafenib and anthracycline chemotherapy in patients with desmoid tumours. The primary endpoint was objective response rate, and secondary endpoint was time to response, progression-free survival, and adverse events. So anthracycline-based chemotherapy provided greater objective response rates and PFS at 1 year and had a shorter time to response, but was associated with higher rates of serious adverse events. The objective response rate for the anthracycline was 37% compared to 13% in sorafenib. And it really was superior across all areas except for grade 3 adverse events. What I do note, though, is that the sorafenib outcomes, so objective response of 13% and PFS of 59% at 1 year, is considerably lower than what was observed in the phase 3 trial. But I suppose this provides good evidence that anthracycline chemotherapy, particularly if you need a more rapid response, it might be appropriate to use as an alternative. The reported toxicity were in keeping with both of the known agents. As I said, with sorafenib, that's PPE, diarrhea, rash, fatigue, whereas doxorubicin saw more nausea, fatigue, rash, and stomatitis. Just looking at the ovarian toxicity again, so it's a variable degree of ovarian toxicity dependent on age and cumulative exposure. So patients older than 40 do have a higher risk of ovarian toxicity compared to those under the age of 30. I don't have it there. We'll cover that a bit later. There's also evidence for paclitaxel. So in randomized prospective trials, that showed very good disease control rates, so approaching 97%, with quite a rapid response with median time to partial response of 6.3 months. Again, relatively well tolerated, with relatively low rates of even grade 3 toxicities, a 2.5% rate of grade 3 peripheral neuropathy. Looking again at the risk of ovarian toxicity, there's a medium risk of ovarian toxicity with taxane-based chemotherapy, although given that this was given for a limited period, the risk is lower due to reduced exposure. So I suppose most of these trials had a limited period of treatment. So the liposomal doxorubicin was a phase 3 trial where patients received 6 cycles, and that's the curve I've included on the left there. So they showed very good PFS rates of 90.4% at 2 years, so very high rates of progression-free survival. And very quickly, I just did want to cover cryoablation because I had a lot of questions about this from patients. The evidence is not high quality evidence. It's retrospective cohort studies from a number of different centres in Canada and France. Overall, they're very consistent, though, in showing a significant reduction in pain, viable tumour volume, as well as showing reasonably good progression-free survival at both 1 and 3 years. So the conclusions from the small papers that have been published are that it's a safe and well-tolerated treatment for near immediate symptom control. So it's probably got the fastest time to action of any of the treatments that we have to offer. I don't know if anyone is interested in doing some little interactive slides, but having a look at this, if you get your phones out, there'll be a QR code on the next slide. This is a 30-year-old who'd been on nirogacestat for 3 years and obtained a good, sorry, wrong patient. This one, this patient presents with dyspnea in this giant, very large desmoid tumour in the chest, so very symptomatic. What do you want to do for treatment? So would you look at surgery? I've spelt nirogacestat wrong, apologies, sorafenib, chemotherapy or other. Okay, I don't think there's that many of us on here, so that I imagine is everyone. There's no correct answer, it's more just food for thought. This one is a 30-year-old woman who's been on nirogacestat for 3 years and obtained a good partial response, but she's been amenorrheic for the last 12 months. So the question is, what would you do with her treatment? Would you continue the nirogacestat until progression? Would you stop the nirogacestat? Would you interrupt treatment until menses resume and then recommence with the dose reduction? And I didn't put an other option, but okay. I think that's interesting. So I think the summary is that there's no head-to-head of all of these treatments. The clinical control rate for both nirogacestat, sorafenib and chemotherapy are all excellent, so often exceeding 90%. So the choice of agent is probably influenced by the toxicity profile and access availability, as well as probably our comfort with using the different therapies. And I think the slight variation in what we all picked probably exemplifies that. That's everything. Thank you.
Okay. Thank you, Stephanie. Any comments at all in terms of the treatment algorithm? So observation was preferable because stable disease, spontaneous regression is well-documented phenomenon. Often systemic therapy for those needing treatment for everyone, or Or should we consider local treatment first? It depends on the size and location, right? Whether resectable or not. Viv, do you have any comment you wanted to, John?
Yeah, apologies I joined late today.
Yeah.
Look, I think desmoids are very challenging tumors, full stop, and trying to pick the right treatment modality, whether that's surgery in rare cases, which chemotherapy to use, local therapies, it's a really individualized decision. And there's often no right or wrong answer. I think cryoablation is actually going to become probably more available. I would like, for instance, at RPA, they're getting better at doing the cryoablations for desmoids now. And one of the advantages of cryoablation is it's usually a single, maybe 2 procedures, which can have really good local control rates without 6, 12, 18, 24 months of chronic toxicity from any of the systemic agents. But the number of tumors that can be that they can attempt cryoablation, you have to be there's got to be pretty strict selection criteria on the tumors they can do that. And certainly for the big abdominal mesenteric tumors, 10-centimeter tumors, that's not a viable option. But in terms of which systemic agent to choose, as Steph said, it's very much can be clinician preference, patient preference, toxicity profile, whether they want to have something IV, whether they want something oral. It can be a long discussion.
Can I add that radiotherapy is a good local treatment option as well. So for those who are unresectable disease, not going down the path of systemic therapy for whatever reason or progress after systemic therapy, radiotherapy can be used. And we treat to about 56 gray in 28 fractions. And our own series looking at about 80% DC control, and there's a mix of stable disease, partial response, complete response is unusual. But you got to tell the patient that the response can be quite delayed, like 2-3 years before you can still see continued reduction 2-3 years after radiotherapy. Liz, you have a question.
Do you think that'll change, Angela, with obviously these are often young patients, it's not a malignancy, and weighing it up against the risk of radiation-induced malignancy later down the line, and given just how effective things like nirogacestat are now, and even sorafenib, but when you actually have effective options, do you think that'll change now as we get more access to things like sorafenib and nirogacestat, how you feel about offering radiotherapy?
Yeah, look, we actually could change a bit. I'm doing less radiation treatment. So more drugs are being used in the younger patient, but it can be reserved for those who progress on systemic therapy or older people not suitable for systemic therapy.
I was going to say, and actually, I was wondering how perhaps other people here, are you starting to use nirogacestat in the first line more? We're certainly using a reasonable amount of it here. I've got a few patients on it because the drug company are giving it to first line now.
Yeah, I didn't know that they give it first line now. I heard
Yeah,
a few times they knock it back before.
Yeah, I think in the last 6 to 12 months they've started agreeing.
Angela, can I make some comments?
Sure, go ahead. Yep.
I just put a link in the chat to the most recent international guidelines, and it's interesting, they're sort of more liberal about doing surgery. The previous guidelines was really first line only for abdominal wall, but the new guidelines say if it's not FAP associated, surgery is reasonable if it's resectable mesenteric desmoid. So I think that's a change, and even sometimes for debulking, which quite surprises me. But separate to surgery, I think all these first line options are possible. Certainly, I think nirogacestat is a reasonable first line option, and as I think Liz said, you can access it first line now. It'll be nice once it's TGA approved and hopefully available. I think even at our centre we have a big variety of approaches. Personally, I think liposomal doxorubicin, although it's toxic, it might be 3 or 5 months of treatment with a prolonged remission, whereas traditionally sorafenib might be 1 or 2 years of treatment. So it's sort of talking to the patients, the trade-off between short but worse toxicity versus less but longer toxicity. And then my final 2 comments, just the ovarian toxicity. I think my understanding is that it's usually reversible. So if someone wanted to fall pregnant, that would be reasonable to stop Nero at that point. But I'm not sure you need to stop it when they become amenorrheic. The hope is they'd respond. And then the final comment, there are some new therapies, beta-catenin inhibitors, directly targeting CTNNB1. There should be a phase 1 trial in Australia coming through soon. They are intravenous treatments, so they're much less convenient, but just to say there's more drug treatments.
Thanks, Peter. And Viv, do you have a last comment?
Yeah, I think the other thing to note with desmoids clinically is that, yes, I know a lot of those studies that are published, they talk about the overall response rate and so on, all of which is quite important. But in fact, you can often get a much better clinical response even before you see a radiological response. So, a lot of the times we intervene is not just because of radiological progression, but because of symptomatic progression, usually pain. And often the pain gets better a lot quicker than time to see any radiological changes. So yes, you can look at the overall response rates and choose your drug based on that, but sometimes you will get a much quicker symptomatic response even without any significant radiological improvement.
Okay, Liz.
Can I ask about people here how quickly you have seen Nero responses? Obviously, I know the data for the paper, but has anyone seen rapid? Because I've had just one who's responded in the equivalent of 2 weeks, and she's gone from 8 to 6 centimeter abdominal wall in 6 weeks. It's incredible. And I just wondered, has anyone else experienced that, or is she just a bit of a furphy?
Well, I've seen the symptoms can improve within 5 days, but the radiologic response can take 3 months. So a complete disconnect between the two.
Right, good.
I'll just posted a paper that's just come out, but that's about, I haven't actually read it yet. I just spotted it on LinkedIn today, but it was it's from Bern Casper, who's the lead of the Nero, was the person who always presented all the Nero data, and it's sort of a position piece about has it changed the game. I don't know if it's any good, but just sharing it as a new paper.
Thanks, Liz. Thanks, everyone, for the great discussion on the 2 papers. So our next journal club is on the 22nd of April. The Queensland team is going to present. So end the meeting now. Have a good evening.
Well done to both presenters. It's great. Really good.
Thank you.
Thank you.